Hello, everybody, and welcome to the final day of the ESNO 2021 Congress. My name is Tamsin Rose, and I have the pleasure of being part of a team of moderators who've been guiding you for the last 2 days and for this afternoon. And just let me give you a little bit of a sense of how everything's going to work today. It would be great to know who's in the audience, so if you could please put in the chat your name, the country where you're working, and your specific speciality. That would be great. It gives us a chance to know who we're speaking to. And just to tell you what we're going to do today, you're going to be invited to keep your cameras off and your microphones muted until the moments when we have interaction, and then we'll invite you to open them up. We're going to start with a session that's forward-looking, looking between now and 2030. What's the options and the future pathway for specialist nurses. Then we're going to, and that's going to be led by Bert and Karine. That will run until 2:30, and we'll take a short 10-minute break. And then you're going to go into 3 parallel sessions. And we are hoping we're going to be able to put you in the workshop that you chose in advance. And if there's a problem, don't worry, you can go back into the plenary and we can reallocate you as needed. But after you come back from the break, you'll be immediately put into the breakout room. And the 3 breakout rooms are looking at how do we move the European specialist nurses agenda higher up the political agenda at European level. The second theme is going to be looking at autonomy and dependency, 2 sides of the same coin. And the third session is going to be looking at the role of the specialist nurse. What can we learn from each other, and how can we, with findings for each other? And the third one, sorry, is looking at the next destination, bilateral, regional, or Europe-wide. And here we're looking at issues of regulation and recognition. And then after we've had our separate parallels, we'll come back to the plenary for final wrap-up. And we'll be finishing by 4:30 later today. Just as a reminder, Care for Nurses and ESNO 2021 are the hashtags. Please use those if you're communicating in social media, and that way we'll be able to capture some of the messaging that you've put out there. And there's a few people who I need to pass some thanks to. The next generation of specialist nurses. And we've heard over the last 2 days about the importance of supporting and giving space to people coming into nursing and specialist nursing. Some of them have made their first steps in the International Congress this year with a poster. And you'll be able to see in the chat the poster page connection, and you'll be able to see some of what they've been contributing. And you're invited to look at that and support their work. We're also reminding you that we've launched a new initiative called Clap with Words. And this is a website to share experiences and stories over the last 12 months, to move beyond the clapping and to get real experiences. And it doesn't just have to be from the nurses themselves. It could be from family members, loved ones, friends, neighbors, parents of future nurses. The idea is to get the sort of totality of the experience from the nursing community and from the people around them, what it's been like, what their hopes are for the future, their worries and their concerns, any messages they'd like to share. So that's the Clap with Words website. And we hope that people will go there, will read, be inspired, be challenged, and be committed to doing things to make a step towards improving the situation for nurses. Just to let you know that ESNO has member organizations, so its membership is on an institutional basis. However, it has opened its doors to any individual nurse who can register as an associate, and then you can engage with their activities. And again, the information about this, you'll find that in the chat. So it's to open them up and enlarge the community of people who can engage with ESNOs. So you can go via your specialist association or a national association, but also as an individual, you can participate, and that's extremely helpful. If your speciality doesn't have an association or an organization that's already connected, you can still play a role in the work of ESNO, and that's very welcome. Just to let you know that at the end of today, we'll have a close and a wrap up from the president of ESNO. So he's not joining us for the opening because, like many people, he has clinical responsibilities in a hospital that he has to deal with today. So that's all the comments I wanted to say. Your participation and active engagement over the last few days has been exceptional. And it's been really a pleasure as a moderator to see that, the level of interest and engagement. And let's keep it up for our last afternoon. Thank you all for being with us, and let me now hand over to Bert and Corinne, who are going to take us into the next session. Bert, Corinne, the floor is yours.
Thank you so much, Tamsin, for this opening. As Tamsin already said, it's the third day, and we are equally, or perhaps even more excited than the first day and the second day. The theme of, as everyone know, the theme of the conference is the specialist nurse in European healthcare towards 2030. So we're trying to look forward, learning from our experiences yesterday, today, but trying to solve any issues which exist either within your locality, your region, your country, and for which you could have support from others from an international perspective. And I suppose that is one of the goals of today, is not just listening to the keynotes, and we have excellent keynote speakers today, but also to be actively involved in the discussions in the parallel sessions, because we really, ESNO would really like to hear from you, as in what are the challenges you are facing, what issues are you dealing with regard to the positioning of yourself or your profession, as well as if you have a particular experience or lessons learned of which you think these are helpful for others, then ESNO is very much willing, as you already know, to facilitate a network for exchanging experiences and learning these lessons. So today is supposed to be an active day, not just sitting back and listening, but actively getting involved, getting your ideas, getting your suggestions throughout the day. And for those who were with the ESNO conference for the last 3 years, you know we have been building up towards today. So in 2019, we invited you to share your experiences, your lessons from all your specialties or all the domains you are active in. Last year, when we were together in Brussels, we were focusing on harmonized education and recognition within a European context. And today, as said, we will be making use of the inputs from 2019 and 2020. But towards the end of the day, we would like to be able to answer that question, as in what is needed to better position specialist nurses in the future health systems, and what are the ways to learn from each other in getting to that destination. Corinne is joining me. Corinne,
perhaps... Yes, I mean, if I could just add, thank you very much, Bert. Or not really add, reiterate what you said, that today is really about sharing, and it's about, yes, maybe getting what we heard yesterday and from what we hear today from the plenaries, but please join in, because this is what ESNO needs. We need to be your voice, and by doing so, we need to listen to it. So it's really your day. We will try and open the sessions up surely in the breakout rooms for your participation. And no matter how maybe you think your experience is not as vast or not as up to the level of others, it is so important for us to listen, because we're all in different levels of what we achieved. and the ones that have achieved probably were in your situation, and they could be able to give some insights on how they have made it today in the specialist nursing field. So this is just my, just reiterating what you said, really, Bert. Thank you.
Thanks, Corinne. Before I'm going to introduce the first keynote speaker of today, a few of the keywords I picked up from yesterday are skilled workforce, skill mix, team lead, leader, trust, leadership, but especially creating the future. And so everyone is invited today, but also tomorrow and the days after tomorrow, is in thinking together with ESNO as in how to create or how to further strengthen the position of specialist nurses in Europe. So how to create a strengthened position of specialist nurses in Europe. So it's time then now for me to invite or introduce the first keynote speaker of today. Lord Nigel Crisp. I'm very excited to introduce Lord Nigel Crisp, who's with us today. Lord Nigel Crisp is an independent crossbench member of the House of Lords, and he works and writes mainly on global health. He co-chairs Nursing Now and the all-party parliamentary group on global health. And he was the chief executive of the NHS in England and permanent secretary of the UK Department of Health between 2000 and 2006. Lord Nigel Crisp his title of his presentation is Nursing Now Campaign and the Future. And I hand over to Lord Nigel Crisp.
Well, thank you very much indeed. And what a privilege and pleasure to be joining with you and creating the future, which is what I think you've just described your aim as for today. And that feels to me absolutely right. You've got to take the initiative and move it forward. Now, I'm going to try and share my screen and show you my slides. So let's see if I can manage this. The host has disabled my screen sharing. Could you enable my screen sharing, please? Here we go. Share. And from the beginning. Here we go. Right. Well, firstly, as I say, thank you for letting me join you. I'm really delighted to have a chance to join you. What I was told is that I've got 20 minutes, but I'm going to make 15 minutes for what I'm going to say and then 5 minutes for questions. So I imagine you put questions in the chat or whatever you do. I'd be delighted to engage in that. Let me start really, though, with a paying tribute to all of you. It's now a year, really, isn't it, with this dreadful pandemic that we're all facing. And I have to say, it's extraordinarily hard. I have lots of friends still working in the NHS here in England and friends around the world. And I know just how tired people are getting, how beaten down by some of the things that have been happening to people. And it really has been tremendous. I mean, I think we all owe a great debt of gratitude to nurses in particular, but health workers in general all over the world for what's been going on. So let me pay my tribute to you and thank you for what you're doing, but also say that even despite all that, you're thinking about the future, and that's really courageous and great and just what you should be doing. So thank you for that. Now, I'm not a nurse. In fact, I'm not a clinician of any sort, but I do know a bit about specialist nursing. I was chief executive of the Oxford Teaching Hospital, or specifically the John Radcliffe and the Churchill hospitals, if people know them in Oxford, in the 1990s. And I seem to have sent my message on earlier, in the 1990s. And it was there that I learned about specialist nursing. I learned about, we had a wonderful wound care nurse. We had great cardiac nurses who actually made an enormous difference in terms of how we treated patients, not only with humanity and care, but also in terms of how effectively we could treat people and actually how quickly we could treat people. And I learned the importance of nursing in Oxford probably more than anywhere else in my career in the NHS. And it's partly that reason, but it's even more my experience in Africa over the last few years that has made me convinced that actually one of the most important things we can do, one of the biggest things we can do to improve health globally, is to support and develop our nurses. And that obviously means specialist nurses, but it means nurses more generally. Too often, as you all know, nurses are undervalued, not able to work to what the Americans talk of as the top of your license, you know, being able to deliver everything that you can do. And that's, apart from a waste of all that passion and expertise and energy, it's also extraordinary waste of resources as well, isn't it? So that's why I have become so convinced of that we need to do more to strengthen nursing, and it's why I set up the Nursing Now campaign. Now, the Nursing Now campaign, in case you don't know, is a 3-year campaign which actually finished, but we've extended it by 6 months this year. So it's going to finish in May, but it started in 2018, and it's a 3-year campaign to improve health by raising the profile and status of nursing. So it's really a health campaign. This is about improving health. It's also a nursing campaign as well, but actually our focus is, you know, and the reason for doing it is because actually by supporting nurses, raising your profile and raising your status, we will have a bigger impact on improving health. And if you and your country or your colleagues are part of the Nursing Now campaign, well, you are not alone. This is just a few of the from around the world. You can tell by the headscarves and others where people are from around the world. That's Malaysia, isn't it, on the top left there? So we've had this extraordinary range of energy and commitment of people joining in our campaign to raise the profile and status of nursing. And indeed, if you look at the world map, in February 2018, we started off, and in December 2020, we had 700 plus regional, national and local groups in extraordinarily 126 countries. Now, there are only 200 countries in the world overall, so it's a pretty good coverage. And can I tell you that most recently, the people who joined the campaign were China in the autumn, Russia in December, and actually Saudi Arabia in January. So we're really spreading into all parts of the world, and I guess probably all the biggest countries in the world are part of it. So you are not alone in part of this, and there's this great movement. Now it's coming to its end, and it comes to an end at the same time as we come to the end of the 2020 International Year of the Nurse and the Midwife, which is one of the things we asked the WHO to do, and they agreed to create last year as the year of the International Year of the Nurse and the Midwife. But we need to leverage the momentum of the campaign to create a lasting legacy. And I'm going to tell you about 3 particular things here, or two in particular. One is that firstly, our Nursing Now groups, the 700 plus groups around the world, have been invited to join and link in with the International Council of Nurses. Really important point that they become part of the representative body for nurses globally. And I know a lot of them are doing so. And the ICN are developing services to continue to support the groups. So if groups want to continue or change their name or continue with what they're doing, then they'll be able to do so with support from ICN. And I think that's really important. The second thing that is, of course, continuing is you may have seen, I hope you've seen, that in April last year, the WHO, in association with ourselves at Nursing Now and the International Council of Nursing, created the first ever State of the World's Nursing report. If you haven't seen it, look it up on the WHO website. You'll find it is a mass of detail. It is the data, it is what we know about nursing globally. And it's the first time it's been gathered together, and I'm sure it won't be the last. And it draws out from that some important proposals for investing in education, in jobs, and in leadership to support nursing globally and improve health for all. Again, the theme that this is about improving health. But what's important about this, as well as having that initial repository of data, is that this is going to be followed up this year at the World Health Assembly in May with the publication of strategic directions for nursing. So the beginnings of a strategy, and there'll be a lot of debate of this over the next year. So in the regional groupings, and we're including the European region, of course, there should be debate and discussion of the strategic directions for nursing, and people like you need to make sure that the European region of the WHO do that. I'm sure they will. But also this year, the WHO has actually followed on the year of the nurse and the midwife by the International Year of Health and Care Workers. And they've done so under the headings, and it's quite a good strapline this, isn't it? Protect our health workers. And that means PPE and so on, protective equipment and so on. Invest and together. This is about the world together and not just about ourselves in our individual countries. And actually, of course, it's about the team of health workers, of which nurses are at the heart, but not, of course, the only members. So there's a really important follow-up work here around this State of the World's Nursing Report. And in fact, we are hoping that we're going to have a set of conferences on May the 24th this year, the opening day of the World Health Assembly, which will start in Australia, we believe, and follow the sun around the world. So an hour and a half in different parts of the world, celebrating the end of the campaign, but the movement through to the future. And we will certainly have one in Europe, and great nurses, some of whom you know, perhaps from the European Commission, people like Adela Zabelegui, I always get it wrong, from Spain, who's on our board, and Elizabeth Adams, the head of the European Council of Nurses and so on. So we will have a good European event then. But the third thing in follow-up is that we launched 2 years ago the Nightingale Challenge, which was a challenge to all employers of nurses, that's the hospitals, the health authorities, the governments, the private providers, to identify 20 or so young nurses and midwives and give them some development in 2020. Provide development opportunities for young nurses and midwives. And development opportunities, not clinical ones, but ones about leadership, about understanding the system, about advocacy, about all those other things which you as professionals bring to the party, and to demonstrate that nursing and midwifery are exciting and rewarding careers. This we aimed for, say, we wanted 20,000 young nurses and midwives involved. Actually, last count, we've got 31,000 young nurses and midwives involved from something like 75 countries. And it's been so successful that the Burdett Trust for Nursing, who has funded much of this, are going to continue it for the next 2 years, and we expect it to continue thereafter. Now, think about this for the future. And I noticed Corinne's comments, was it Corinne's comments, but Tamsin's comments, was it about young nurses coming into specialty nursing earlier. These are the future. You know, we say young nurses 35 and under is how we've defined young, although of course we're all young on this video, aren't we? But they're the future. And can you imagine there's a network now of 31,000 young nurses and midwives around the world, how powerful that could be. And if it's added to next year and next year, this is going to be a really growing network, and you've got to use the power of that network, I think, to make change happen and to create the future as we've been talking about it. So those are some of the things we're following on Nursing Now. So the Nursing Now campaign was always intended to be 3 years and to try and make a step change. But actually, there's generational change needed here, as you will understand better than I do, that this will take a long time. But we're moving in the right direction. And let me talk again about why I think nurses are so important, and why I think nursing will become ever more and even more important in the future. And there are a number of reasons for this, and they're shown on this slide. Firstly, diseases are changing. I don't need to tell you that. But, you know, we've got this big increase. If we leave aside the pandemic, where nurses, of course, have been in the front line in every sense, but we think about the biggest burdens of disease, even including infectious diseases, which are the non-communicable diseases, the non-infectious diseases, that whole area from cancer to diabetes to asthma to dementia and so on. And if you think, as you all know better than I do, about the way that patients in those areas need care, it fits perfectly with nursing. And indeed, we have seen, haven't we, and I see on the call here, a range of people lead nurses in diabetes and so on. You know, we are increasingly seeing nurses taking the lead in the biggest areas of where where the disease is moving, where the burden of disease is. So epidemiologically, technology will be pushing forward the importance of nursing. But so will the way in which I think all of us are starting to see health. We're moving away from a purely biological model of the world, and we're thinking much more in terms, aren't we, of a biopsychosocial and indeed environmental view of health, recognizing all those determinants of health. And that, of course, as I understand it, fits very well with the way you are educated as nurses to take that bigger perspective, that more holistic view of health. And that's the way the world is moving. I think there are also big arguments about value and quality, in particular the areas of person-centered care, but also value for money. But here's a really big point, and this is for the older nurses amongst you. You have created a track record. Yeah? Some of the things we're talking about now in nursing, we couldn't have thought about much 30 years ago, or we could have thought about them, but we couldn't point at them. But in my country, I can now point at people, say, look, that's what a specialist nurse does. That's why you need nurses leading in diabetes. That's why you need nurses in cardiac surgery, to being specialists or nurse consultants. So there's track record and there's evidence, and it wasn't there before. So the timing has changed. Another important point, a big point about society, is that nursing is not a gendered profession. And, you know, great credit to all the men in nursing as well as the women in nursing. But it is a majority of nurses are women, and the changing status of women is affecting how nurses are seeing. And my observation from around the world as part of this campaign is the way nurses are treated in a country relates very strongly to how women are treated in that country as well. So there's a big gender perspective here and a changing one. And then finally, COVID. And what's happened with COVID, as I'm sure in my country, and I'm sure in other countries as well, is that we have seen a real increase and recognition of the importance of nursing. We've got an interesting pair of phenomena happening at the moment. One is that some of the older nurses, some of the people who've been in the profession for a long time, are saying that they can see that, you know, they're tired, that actually when this is over, they want to retire, they want to move on, or they want to break. But we've got record numbers of people coming in at the other end. We've got record numbers of people applying for training and education in all the health professions, but particularly in nursing. Nursing, I think, has achieved a big profile boost because of COVID, unintended, unexpected. And of course, none of us wanted COVID, but it is something that I think is changing the environment. So what does that mean for the future we're creating? Well, it means, as I've said, nurse-led clinics, many more nurse-led clinics, specialist nurses and more nurse practitioners. Again, in our country, we've got a lot of emergency nurse first responders as practitioners. I think actually another area where nurses are going to be playing a much bigger role in the future is primary care and community services, of course, and particularly care at home. Bizarrely, in my country, we've been reducing the number of community nurses, but we need to reverse that from where we are. And I suspect that primary care in the longer term will become essentially nurse-led. That would be my perspective on it. Over 20 years, I think we will see that it will be nurse-based with doctors and pharmacists and all kinds of other people linking in, but the continuity of care in the primary setting, I think, will be led very strongly by nurses. And you can see that starting to happen in some places. And then finally, the other area, of course, is in public health and in what I call health creation. Let me just take 1 minute on this. I think I've probably got time to do that. In health, we always talk about the causes of ill health. When are we going to start talking about the causes of health? And there's some really important stuff that is done around, sometimes called salutogenesis, but it goes back to the Greeks actually, in terms of how we live our lives. And I recently have taken a big interest and written a lot around creating health as opposed to just preventing disease. And I think nurses can play a great role in that. And I use an expression I learned from an African friend: health is made at home, hospitals are for repairs. Now I know hospitals do more than that, but you get the point. You know, it's actually schools and what happens in schools and work and at home and in the family and our relationships that create health. So there's the future as I see it. And if you look at that little chart there, you can see why I created Nursing Now. You know, I mean, this is Really important that we build on what you have achieved, and remember, you have achieved with your track record as specialist nurses and other people in other parts of nursing to make things happen. So let me finish on this note about taking action, because I know you wanted to ask me about what I thought you could do to raise your profile and so on. 3 quick bits here. I mean, of course, there is advocacy, and you've got to keep finding all the platforms for advocating things, and you've got to find all the ways of engagement. You've got to get onto boards, you've got to respond to consultation, you've got to join in, you've got to think your voice is important, and so on. And that's important, and that's all part of all of this. You've got to meet people and talk to them and explain your story, and you've got to have the evidence, and that's increasingly there. But evidence is never quite enough by itself. Making change happens not just with evidence; it happens because people buy into it, because they get your point, they understand what you're talking about. And some of that is about stories and allies. It's about telling stories about COVID and what happened and why the nurses were doing this, and getting people to understand that, but also finding people outside the profession, like me, but outside the profession, to be your advocates. Because talking about yourself and saying how good you are is one thing, having other people also saying how good you are, that actually reinforces it massively. Very brief story from my time as Chief Executive of the NHS. In 2003 or 4, I can't quite remember, we introduced prescribing for nurses. So prescribing from a limited pharmacopoeia originally, and of course taking additional training before doing that. And the biggest advocates, the biggest opposition to it was the doctors, and the biggest advocates for it was the doctors. I leave the nurses aside. So I had doctors coming to me and saying, you've got to let these nurses know what they're talking about. They were talking about the people actually who really came to me were the palliative care doctors. They say, our specialist nurses, we agree at what point you're going to increase the opiates or whatever. We know what we're doing. You don't you come and find me to sign a bit of paper. This is part of a team. That's how we work. And they, as doctors, were in some ways more convincing than you as nurses. And I'm sure you can understand and that's not just about the power of the doctors, it's about people from outside saying this is important as well. So it was the doctors and nurses making that advocacy. They came to me as Chief Executive, and then of course we had to deal with the opposition, and we had to lay out the evidence. We took a year. We took a year of really looking at the detail of it and set up expert panels and so on. So we did it really seriously. But what mattered was people got it. What mattered in the end was that Tony Blair, as our Prime Minister, understood. He got the story and he heard it from more than one person. And then finally, on taking action, join in. Make sure you're linked in regionally, as you are obviously in this European group, but also nationally in your own country, but globally as well. Contribute to the consultations wherever you have them. And then finally, well, thank you for listening to me, and good luck for the future. And my final sort of takeaway message is, do retain hope and ambition and energy. It's a long journey. This isn't going to be sorted out in 5 years and 10 years or whatever. I mean, and I know I've met colleagues, nurses in Spain and Italy. I think of visits I made, what is obviously 18 months ago now, talking with them about what specialisms we're developing and what a long journey it is to take. But it's a journey that you can make, and a journey that you can create, and a journey that you can use COVID and your experience to date to accelerate. So on that note, very happy to take a few questions if there's still time, and thank you very much. And I'll stop sharing this screen.
Thank you so much, Nigel, for this excellent presentation, and congratulations with your campaign. I think we are all happy to see that the campaign is being translated in activities throughout the world. Perhaps one question let me see if there's any questions in the chat, but perhaps one question for you, a quick one is, and maybe it's a big question, but then again, we would like to challenge you, and you have given us some action points, I think, which are very actionable. So the global campaign plays out internationally, right? Your field is global health. How challenging is it in terms of translating lessons from a global perspective towards a national perspective? And I think the example you've been given, as in legislation, prescribing authority of nurses, plays out on a national level, right? And we can pick this up, this experience and lesson, but how challenging is it to make use of such experiences or lessons in different countries, different cultures with different legislative systems? Is that something you have been addressing as well as part of the campaign?
Well, it's a very great question, Bert. I mean, the global perspective at one level doesn't matter. It's the least important. The most important is the local. And we're going to do a report for May the 24th, that we'll publish it before it, of the campaign. We're not doing an evaluation, because the evaluation, you can't evaluate it for another 5 years or 10 years, you know, down the line. But what the evaluation will look at is what's happened in a number of countries. It doesn't matter what happens globally. You know, you just talk globally. You know, there's a lot of people who make a living, as far as I can see, going around global conferences. But actually what matters is what happens in countries. So we've taken a number of examples, and they range from Uganda to Pakistan to Mexico, around the world, of where people have made changes during these 3 years, including significant investment in countries like Pakistan, for example. And really quite significant changes that are happening, and those are the stories that matter, and the local stories, and those are the bits that matter, and that's how we will. What happens on the ground is how we will evaluate whether this is worthwhile or not. But you make a terribly good point, which is how do you translate good practice from one arena to another arena? Now there are ways of doing that. That are now sort of tried and tested, but it isn't about taking this and putting it there. It is actually very often about mutual learning, and there's a great process designed by a group called IHI. I don't know if people know the Institute of Healthcare Improvement, the Breakthrough Collaborative, where actually if you you're in England, aren't you? I think, but people in different countries around the world are trying to do similar types of things like nurse prescribing. Then they share their lessons, you know, and they say, we tried this and it didn't work, or we tried this and it did work. And they say, well, we tried that and it did work, or didn't. And once you share it across people like that, you then start to accelerate change. Now, I'm describing a longer process you know, fairly crudely. But there are methodologies for doing that. But what we must never do, and particularly those of us in rich countries, is try and lecture people in low and middle income countries and say, yeah, you should be like us, or you should do it like this, or whatever. Which is why, incidentally, we've been very, very careful in our campaign to stay away from some of the issues about how you train nurses, for example, because actually, you know, some of that, the context is just so important, isn't it? You know, and if you're in Papua New Guinea, or if you're in upstate New York, these are different environments, and what's at the heart of it is how you as nurses see the world. It's your values and so on, and your ability to see holistically, and then your ability to determine what needs to be done there.
Right. So
long answer to your question.
No, that's okay. Let me try to summarize it in a few words. I think it's the challenge here is to identify best practices and to identify the mechanisms behind those best practices, and see if those mechanisms, how they fit within the locality, the culture, the legislation, and so on. And then I suppose come up with a implementation plan, as in how to overcome specific barriers, but also learning from other countries, right, where these barriers have been overcome.
Yeah, I just add one thing to that. Yeah. I mean, that's right, but it's actually about relationships. You know, it's about people thinking and doing things together, and I think it is so important. You know, you can draw nice graphs about this, and it is absolutely right that you can identify best practice and then best practice in how you spread best practice. But you know, put people together and they create. You know, I'm a great believer in putting people together, the right people in the room, and I don't know what's going to come out of it, but it'll be good. I'm an anarchist at heart, as you can see, despite having run the biggest health system in the world.
Excellent. Thank you so much, Nigel. Thanks for being with us. I'm sure there will be more questions, and if that's okay with you, we will make sure that these questions will be sent to you, and if possible, if you have a moment or so in the beginning of next week, if you can please respond to those questions, or we will make sure to share your answers as well as your presentation with the audience. Thanks again for being with us. Congratulations with the campaign. I'm sure ESNO is very exciting to learn from the campaign, and perhaps also to play a role in the next steps from May onwards, I believe. You already mentioned Australia as where I suppose the next phase is gonna start. And we do have, I'm very excited to introduce the next speaker, who is actually from Australia with us today. And that is already a big achievement for joining us in Europe, all the way in Australia. Michelle Gunn is joining us. Michelle is Director of Nursing in the Queensland office of the Chief Nursing and Midwifery Officer, where she has responsibility for professional capability statewide. Michelle, the title of her presentation is Specialty Nursing in the Australia Context, Balancing Regulatory and Professional Issues. Michelle, over to you.
Thank you, Bert, and thank you, Lord Nigel. That was a fantastic presentation to kick the afternoon off. Welcome, everybody. It's a real honour to be with you all the way from Australia, although these days, actually, since we've all learned how to use this technology, it feels like our world in many ways is more divided than ever, but obviously through technology, we can be together in such a great way. Today, I'll just share my screen. I'm not quite sure what you'll see, but just give me a little moment. And then we'll get started. Just a little moment here. Yep. Okay, thank you very much. Yeah, today I'm going to be speaking about specialty nursing in the Australian context. And I'm going to have a little bit of a go in a short period of time at balancing regulatory and professional issues. I have done a lot of things in my life with nursing and that, but the one thing that I'm really proud of is my family. And I think for me, it always brings back to me the services that we provide to people are the services that we would want from our own family. So there's my tribe. I have 5 children, and my husband is the second from the left, which with my boys getting so big these days, it's getting a little hard to tell who's who. All the way from Australia. Australia is a really remarkable place, and I'm incredibly proud to represent Australia. We are an island. We're also a country, but we're also a continent. So when a lot of people have the idea of Australia as a sunburnt country, they're often surprised to see that we've got ski fields, we've got tropical rainforests, we've got beautiful beaches. We're really quite a lovely country, and we love visitors. So as soon as our borders open up again, I'd like to say, please come on down. A little bit about COVID, and I just want to acknowledge the torrid time that everybody's had this year. But I think it is, like anything, it's good to share sort of positive stories as well. Being an island, we had a strategic advantage. Being an island, a hell of a long way away, we had a really, really strategic advantage, and we were able to close our borders early. So we have actually no cases today, 5 active cases in Queensland, and for many months we haven't had any community transmission. So I don't put that out there to make anyone feel bad, because I know that around the world it's been a tough gig, and we've had some tough gigs actually in Australia. We've had some outbreaks which have shocked us at how rapid this horrible virus spreads. But I do put that out there as hope for people as well, that we can get together and we can contain this. And we commenced our vaccine program this week. Today, I'm going to talk about a few things as I sort of start to unpack this notion of specialty nursing in Australia. I want to talk a little bit about the Australian nursing context, because I appreciate that's probably not something that most people in Europe spend a lot of time learning about. I want to talk about our national regulation and our national law, our National Nursing Board, which essentially has oversight of that aspect of the law for nursing and midwifery, and how it deals with specialty nursing practice. I want to share with you a little bit what it looks like in Australia's specialty practice as well, because as Lord Nigel was saying, increasingly we've got to take a holistic view of what we do, and we've got to take into account that it might be different in Australia as opposed to where it might be in Papua New Guinea or even in different parts of Australia. Then I want to bring together some professional issues with the way in which it has been approached in Australia. I don't say that to be negative to my Australian colleagues, but I think they're just some of the issues that probably will resonate with many people around the world, that we haven't quite got it all worked out yet, and some key messages to close. Okay. Oh, my apologies. Just go back. Okay, in Australia, and there's a beautiful picture there from the Australian War Memorial taken during the Second World War in Europe, actually. Historically, Australian nurses were trained in hospitals, and in the Nightingale tradition, there was the traditional 3-year program, hospital exams. There was a very limited scope of practice, and specialty was through a certificate system. So you would hear some of the older nurses talk about being triple certificate, which would mean they had a certificate in general nursing, maybe child nursing, and maybe midwifery or something like that. So that's how specialisation was traditionally looked at in Australia. Badges were very important, and they're still very symbolically important in Australia, and the state at the end of training would actually acknowledge badges, and definitely a lot of the specialty associations over the years have handed out badges which nurses have used as a proud example of their competence and their specialty skills. Right from early days, Australian nurses were advocating for university education, and in the 1930s in particular, there were quite a number of bids, but surprisingly, they were opposed by our medical colleagues. The first Australian nurse that we could track down that had a PhD, got the PhD in 1970, although she did not get it in a school of nursing, because we didn't really have a school of nursing. She had to go into another discipline school to get that. But things have really quite changed a lot since then. And by 1993, we had all of our preparation of our registered nurses move into the tertiary sector. And now our university scores for nursing, and I think Lord Nigel was actually right about the increased numbers and interest in nursing, but our scores for entrance into nursing now are routinely higher than engineering. And in some cases, and especially for the dual degree of midwifery and nursing at our University of Queensland, it is equal to an OP1, which is the score that you would require to do medicine or physiotherapy. So I think that for nursing says that nursing's actually come a long way. In Australia, we have now coming close to 400,000 nurses and midwives registered, and we have as a percentage of population, we've got about 1,200 nurses per 100,000, which is incredibly high by world standards. With that comes the responsibility that we are growing our own and not obviously relying on nurses from overseas, which probably has been a bit of a tradition in years past. That said, we're always really elated to have nurses come from other parts of the world, as we're a multicultural country, and as a country that is so far away, we always enjoy the things that other cultures bring. In Australia, the salaries for nurses are quite high. A graduate nurse, I had to do a little bit of playing around with numbers, but roughly, I think, so I can't actually see all of my screen with it. I just might move across. Yeah, a graduate nurse will earn about €50,000, whereas an executive don about €145,000, which is quite a considerable salary indeed. And in Australia, there is increasing growing demand for specialty nursing skills. So I might just move on a little bit past that. Since 2010, we've had uniform national law, and that was a big move away from the state system. So although regulation of health professionals comes under the jurisdiction of the states and territories in Australia, this was basically a piece of legislation that was simultaneously or thereabouts passed in all the states and jurisdictions so that we would have a seamless law, despite the fact our constitution really never envisaged such a thing. This law established a national scheme for registration and accreditation of health practitioners, but also students, and established the 14 national boards. So each, not all of the health professionals have a national board, but the ones that were perceived to be at more risk to the public came into the scheme, and there's 14 of them, of which nursing and midwifery is one. This legislation does many things beyond what we can talk about today, but one of the really important things is it actually has protected titles, which means that to hold yourself out as a nurse or registered nurse or a nurse practitioner, you need to have undertaken the requisite training and be registered with the board. And to hold yourself out as one of those titles and not be that can attract a fine of up to 60,000 Australian dollars. And I think for corporations, it's actually gone up even higher now. The objectives of the legislation really fundamentally are said to be the protection of the public, to make sure that only people who are suitably trained actually are registered as health practitioners. The other sort of objectives are around workforce mobility, because across Australia, if you had to register in each jurisdiction, it actually restricted people moving around Australia. And although Australia is a series of states and territories, we really just see ourselves as one country. So that was always sort of somewhat problematic. It's also about the facilitation of high quality education and training, and to have also a flexible, sustainable workforce as well. So if we hold that in mind, and I think it's really important to hold that in mind in terms of as we look at how specialty nursing is actually dealt with, because we might find that maybe there might be some misalignment with that down the track. I will come back to that though. Under the national law, as I said, we have a Nursing and Midwifery Board of Australia, and the Nursing and Midwifery Board is where essentially the work of the national law is handled. So they do the registering of our nurses and midwives, they develop the standards, the codes, the guidelines, and they handle the disciplinary matters. So if there's a complaint that needs to be looked at, they handle that. They also do assessments of our overseas trained nurses as they're coming into the country, and they approve, and really importantly for specialty practice, they approve accreditation standards and the accredited courses that lead to registration. I will actually sort of do a bit of a spoiler on my presentation here. They don't actually do that for specialty areas. It's for the undergraduate preparation, and it's also for the nurse practitioner preparation only. So I'm probably giving this away, but in 20 minutes, I haven't got a lot of time. So having a little peek at some issues around the levels of registration in Australia, we have kind of 3 levels, but 2 main levels. We have enrolled nurses who essentially do a vocational training program of between 18 months and 2 years. And then we have registered nurses who undergo a bachelor prepared program. And then a registered nurse can be endorsed as with 2 things. She can be endorsed as a nurse practitioner or endorsed as a rural and isolated practice nurse. Now, while a nurse practitioner is recognition of, well, advanced practice at least, or some degree of specialty practice, I suppose, the endorsement for rural and isolated practice is soon to be withdrawn because it has been clarified that that endorsement was only ever for the purposes of scheduled medicines legislations in jurisdictions. It was never recognition of specialty, which has been a disappointment to many nurses, but definitely makes the point around specialty recognition and where we're going. One of the key factors of our national law and regulation is the requirement that all nurses and midwives work within their scope of practice. And I raise that because it's a really, really strong regulatory catch-all that essentially says that nurses must, and it is a bit of a complex concept, but it really means that you must practice within the things that you are educated, trained in, competent in, that you have recency of practice, and that you have the legal authority. And that legal authority takes into account your employment conditions. So scope of practice in Australia is this really dynamic concept that depends on the context of practice, depends on where you're actually practicing, and is a relationship between essentially your own personal attributes and those of your employer in the context of your employment. I will mention that because I think that is actually one of the real things that actually maintains the high standards, and it is the importance that nurses in Australia put on that that is very important. Just on the right of your screen, you'll see there is a diagram there. That diagram is essentially sets out how our nurse practitioners are regulated, and you can actually see that while there are a number of standards that have been developed, they are general standards, very, very general. So our nurse practitioners are not specialists in the sense of being a specialty or specialist nurse, as I probably generally think, but they are actually generalists, and they also have the domains going across. So it is, again, as I was just pointing out, it is actually a generalist model. The Nursing Midwifery Board of Australia has explored the concepts of specialty nursing and also advanced practice nursing. And these concepts really have caused people a lot of confusion. People get, I'm not quite sure where we're going with this. And advanced practice, I think it's fairly settled, is a level of practice in Australia. So it's really sort of saying that you may be working in a general area or a specialist area, but you can be working at various different levels of practice. And of course, to progress through the levels, we have a strong model, we call it, and there's 5 core domains that need to be satisfied, looking at leadership, education, research, the support of, I feel like I've left one out there, maybe one, leadership, yeah, education, research, support of systems. Anyway, there's 5 of them, and it is really important to progress across all of those as you go through. As I said, advanced practice can be in the for a generalist, or it can be for a specialist. So again, advanced practice really isn't true acknowledgement of specialty. So in the Australian regulatory framework, there really isn't, beyond the NP perhaps a little bit, but not really. There really isn't any recognition of specialist nursing. But there is this recognition that specialist nursing is a context, and that's something that we are working on increasingly. And I've got a picture of the koala there with a baby, mostly because we have to say that's one of the most specialist animals. They're very fussy, and they've adapted beautifully to their environment. They only like some context. So I just thought I'd throw a few Australian animals in as we go through here today. Now, looking at Australia from a specialist context point of view is actually really quite complicated. We have cardiac nurses, and we've got renal nurses, and all of the specialist nurses that you would actually expect us to have within the metropolitan context. But then we have this whole overlay as you move outside these areas out into our rural and remote communities. And our rural and remote communities are a really long way away. I had to visit one of my sites out at Mount Isa, and I was on a commercial plane for 2 hours to get there. So, you know, many of our generalists who work out in these areas actually have to be specialists at the same time. You start to see context on top of context on top of context. So there may be an Indigenous context, there may actually be a generalist context, there may be a dialysis context. And if you can see that truck on the screen there, that is a truck that has been dispatched from Central Australia. There's a house there called the Purple House. It was a community initiative for some Indigenous artists got together, community artists got together and painted some amazing paintings, sold them at auction, raised $1 million and set up a mobile dialysis unit. So they go around so that people can have their dialysis within their communities. I mean, to me, that is the best of context on top of context on top of context, but it also brings home how incredibly highly specialised these types of nurses have to be. They've got to not only deal with the specialty of dialysis, but they've also got to deal with so many other issues not only the tyranny of distance, which is a huge one for our nurses. Because of time,
Michelle,
and I'm not quite sure
I'm
how
sorry,
I'm going
we
with
have
time.
to, yes, you're over by 2 minutes, but we took a couple of
then I
minutes of
might,
your time,
I'm
so
sure.
if you could conclude. Thank you.
Thank you, Corinne, that's great. So there are a whole heap of professional issues. There's essentially no consensus on specialty nursing contexts. There's many small associations that find it difficult to maintain their educational standards because they just don't have the funding or the volunteers to do that. A lot of our postgraduate courses are fabulous, but they're often driven by universities and business models. They're not always underpinned by what our industry and professions need. There's still a lot of on-the-job training, even after people have done these courses. Professional credentialing is actually not supported by industrial partners, so there's not a lot of funding, and then it doesn't turn up in our awards, so you don't actually earn any extra money for being specialised. And a lot of our there's not a lot of public investment in the education as there is with our medical colleagues. Essentially, the career pathway is actually really at risk at the moment, and I think there needs to be some policy work done, and part of that is actually getting regulatory recognition. I've got a picture there of a platypus. I put that up, and I'm going to just jump to the chase because there's a lot of statements said by people in Australia about specialty practice, and they actually say that it doesn't actually improve the standard of care or public protection. I think that tells me a little bit like a platypus because it just doesn't kind of make sense to me. A platypus lays eggs. It's a mammal. It's got poisonous spur. It's cute, and it looks like a duck. I'll let you guys look it up. Just in closing, because I realise we're out of time for today, there is the beautiful city of Brisbane, who is likely to be the host of the 2032 Olympics. So if we're going to look down the track, I hope you come for a holiday after we've achieved all the things that we hope to achieve. But if I can say, in Australia, nursing, like around the world, is really evolving, and specialties are really evolving along with it. But our national law doesn't really recognise it yet, and there's more work to be done. I think myself, the conversation around specialty nursing is just too complicated as a policy issue. And I think that gets in the way. We get caught up about advanced practice levels, domains, and not actually really that we need investment so that we've got educational standards and that we've got, the programs and so forth for our nurses to develop. I think I might just cut to the very last line, and I'd say that while professional recognition of specialty nursing is a first step, that we recognise and understand it, we've really got to get that legal recognition to attract that investment, assure standards and protect the public. Thank you.
Thank you so much, Michelle, especially for providing us this excellent overview in such a short time. But I do think we have even more than a feel, I think, of where nursing is in Australia. Perhaps one quick question. What's first on your list in terms of strengthening the future of specialist nurses in Australia? What's the thing which is first on your list?
I'm actually doing some work around the rural generalist at the moment, which is a specialty context. I think it's actually attacking the problem from a number of different angles. But as I said just a moment ago, I think having a simple message, I think the policy message has actually been too complicated. So I want to look at it from a regulatory point of view. I want to look at it from an educational point of view, from a professional standards point of view. I want to look at it from an industry point of view. What does the industry need? What do we need for education? And then what about the industrial aspects of it also, so that it works for the actual individual? Because what we're finding is we have a lot of graduate nurses who have got generalist skills. But as we're seeing our retirement start to kick in, as people, the baby boomers are starting to retire, we're starting to see the big gaps emerging in our specialty areas, and we have to do a lot of rapid movement, and there have to be incentives for people to go into that space, and also the investment to get them there.
Excellent. Thanks, Michelle. You're with us, right, throughout the rest of the program. So
I'll stay with you as long as I can stay awake. It's coming towards, it's after 11 o'clock and I'm a bit of a nana, but yes, no, I'll stay as long as I can. Thank you.
Thank you. That's wonderful, because then we still have later on in the program time for more questions. Sure. Let me move on to our third keynote speaker of today. So we're moving from the UK to Australia, back to Europe, to Leuven, Belgium, I think, or near Leuven. It's my pleasure to introduce to you Professor Walter Sermeus. Walter is a professor of healthcare management at the Leuven Institute for Healthcare Policy of the University of Leuven in Belgium. And Walter, he is also program director of the Master in Healthcare Policy Management and head of Leuven's WHO Collaboration Center on Human Resources in Health Research and Policy. And his contribution is about the nurse specialist contribution in healthcare provision towards 2030, the minimal required steps. Walter, over to you.
Thank you very much, Bert, and it's wonderful to be with you here for this conference. I always enjoy the ESNO conferences, so they are quite inspiring, and we had 2 inspiring presentations before me, so I hope to meet them in the expectations in some respect. I open my slides. So the question was, where are we now with nurse specialists, and what is the what is the future, and what way to go, and what are the required steps? I will give you my opinion. I don't think there are many ways forward, but I think, as Nigel Lord Crisp was saying, I think the future is bright, and it's also the theme of the conference in creating the future. I think to do that, we have to go look back and to see where we are. And I think what I would like to do is to focus on the role of nurses and also specialist nurses during that COVID-19 pandemic we are in, because I think it's important to understand where we are and in which way we go, and then some instruments that are provided by the European Commission to work on that. So I just want to refrain some of these steps that can be taken. But let me guide you to the COVID-19 pandemic. We all know there are different phases in this pandemic, and the first thing what we should do is of course prevent, and so we have to prevent to become sick. There are some different measures, as you all know. It's like social distance, mouth masks, hand hygiene, ventilation, and the new thing coming up is in vaccines. So that's the first thing to do. Of course, we have to screen, because some people can become ill, and that's what we do with testing, contact tracing. We put people in quarantine. If they become sick, then we start with the treatment. Most of these people can stay at home, so the disease is mild to moderate. They stay in self-isolation at home. They might be asymptomatic, or they might have some symptoms, but altogether it's mild and rather moderate. But we know that some people are admitted into the hospital, have some disease problems, certainly in breathing, and some other problems, and some of them end up on ICU, have some critical care, or need some critical care. Altogether, when we look to the data, I think altogether in Europe, 95% of the people in our community stay healthy. We have about 5% of the people that become ill. What is a low number still? And so the number is varying from country to country. So I'm looking to the numbers all over Europe. It's about 1% in Finland. So not many people are getting infected over there, up to more than 11% now in Czech Republic. And that did severely hit, as we all know. And just to give you complete the data, about 80% of the patients or the people get mild to moderate symptoms or no symptoms at all. Only 20% are admitted into hospitals. And from that 20% that are admitted into hospitals, about 5% are getting into ICU. And so the death rate, case fatality rate, is about a little bit more than 2%. Of course, this depends severely on your age groups or comorbidities and so on. So when you're a little bit more obese, or you have some comorbidities, this infection rate or this rate can be a little bit more. One of the most interesting publications I've read during the last year is a publication by Imperial College in March 26. And so it's about the estimates. And I just want to tell you about the estimates. And the estimates were done by Imperial College we estimate that in the absence of intervention, so if we do no prevention, if we do no treatment and so on, so because that's an important type of data, COVID-19 will result, and that's all the data for Europe, for the European Union, in fact, this will result in 391 million infections for Europe. So it means that 88% of all population would be exposed, and 4.4 million deaths in the EU this year. And looking to the data now, and I checked the data yesterday on Worldometers, we have 22 million infections and a little bit more than 500,000 people being died from the disease. Of course, every death, every person we are losing, it's a tragedy. That's how it is. But I think, and it's important to know, and it's important to reassure, and I think that's the role we are taking as the health community and as a full community, that we saved 3.8 million lives in the EU by all the measures we are taking. And I know that most people are focusing always on the negative things. Of course, I think these prevention measures are not quite nice to do. The lockdowns are not quite nice. The evening clocks are not quite nice. It's of course it's a catastrophe when you're losing a patient in intensive care. But we have to know, and that's the result of our efforts, that we saved almost 3.8 million lives until now. 88% of the population was saved. And I think it's quite important to say that. And so this is mainly by the role we are playing in our healthcare system. So it's of course not the role of nurses alone. It's a role of social services. It's a role of communities. It's a role of people that take a responsibility about their own health and are really, really be very careful. It's the role of doctors, it's the role of physiotherapists and so on. So it's a whole community, but it's also the community of nurses that is really contributing to it. And I put a few examples over here. I see community nurses do an incredible amount of work in working with communities, with people. They work on public health. They really are teaching people why this is important, how they have to wear masks, how they have to wash their hands, what ventilation means. They're now actively involved in the vaccines. They are involved in the testing, in the contact tracing, in the quarantine. They are working with people at homes and checking if they are doing well. And then we have our heroes in the hospitals, dealing in the ER nurses, respiratory nurses, infection control nurses, ICU nurses, rehab nurses. And we see all these connections, also these people going into nursing homes and at the home as well. I see in this country, in my country, in Belgium, that a lot of infection control nurses were going into the nursing homes and help their colleagues how to deal with prevention, how to take some protective measures. So I think this is the community that's existing. And so out of that, I think this is where we are going into the new paradigm. So the new paradigm is not 2030. It's not by accident 2030. It's a new health paradigm after COVID-19. And I think COVID-19 is really a stress test for the healthcare system and for the whole community. And so I see some shifts going on. I see some shifts from the medical dominated healthcare system into more interprofessional teams. I know that in the past, healthcare was very focused on hospitals. What I see now, it's moving into integrated health networks, including prevention, including being at home and keeping people at home healthy as long as possible. And only when that is not possible, we can bring people to hospitals. But it's a complete other mindset, how we look to the healthcare system. We are dealing with populations, not only with individuals. We're putting more effort on prevention. That's what I learned certainly in COVID. So the biggest impact is in preventing people to become sick. That's what is the most important thing. When they become sick, of course, we have to handle, we have to take measures, but preventing them to become sick. And then, of course, the full impact. We are talking about health. And so in our country, we are talking about the power of the virologists. But at the same time, we see all these psychiatrists, psychologists, and so on, really working with people, talking about their well-being, about economical consequences, and so on. So it's a total community that is involved in when we are talking with this crisis. It becomes very proactive, evidence-based. We are talking about the data every day. And I think there was no crisis before that was so documented as this crisis. We are really looking to mortality. We are looking to complication rates and so on. We are following the infection rates day by day. And it's really not about the professional, but it's mainly about citizens and patients. And it's about behavior and change. So we are saying in the healthcare arena, what we think is in 2030, we'll have to behave differently. We learn how to a new life, and that's what we see. And yeah, coming back to our healthcare system, it's not about beds or hospitals, it's about people, professional knowledge and skills. And certainly when it's concerned about specialist nurses, I think that's what we see. We see that we lost lives because we didn't have enough skilled and knowledge people to care for our intensive care patients. We were losing lives because people in nursing homes were not skilled enough to take the protective measures that were really necessary. So it's really moving into knowledge and skills. And so where we are in Europe then, we have that automatic recognition for nurses responsible for general care. So it means that some regulated professionals can move from country to country. They're recognized in an automatic way and programs are recognized. What I see, we have the same thing for medical specialists, but we don't have it for nurse specialists. And I think this is quite important. So the movement is not important. I think that people want to move from one country to another country, but that's not the main point. The main point, there is no general framework for nurse specialization. And I think the framework is important to really understand what the role is of a profession and what the contribution is. And what I learned certainly from COVID is that it's a huge contribution from specialist nurses into the community. So I think this is important. Now they have to use a general system. I think it's a long way, but it's more important to move forward. And yeah, the new directive introduced something that is called the Common Training Framework, the CTF, to make the process of professional recognition easier. It's required a common set of minimum knowledge, skills, and competences. I think it's an important instrument that can be used by specialist nurses for the future, in line with what medical specialists did for their specialization. Just go to the common framework very briefly. The condition is that the profession of the training should be regulated in at least 1/3 of the EU member states. I think most of what the specialists are doing is being regulated in most of these countries. I think about oncology care nurses or intensive care nurses, anesthetist nurses, and so on. So in most countries, these professions are regulated. So the condition is more or less fulfilled, and it would be good to know how it really is in Europe and what the status is right now. But if this is the case, then a representative professional organization can take the initiative to start this coming training framework. And I think it might be one of the organizations around the table in our audience, or it can ESNO who can take the initiative. It can be also competent authority that can do that, but it can also be a national professional organization who can take the lead. And you should not do that by one country or by one organization, but you should involve at least 1/3 of the member states in that way. What you need to do that is to collect some data first. And I think most of the organizations also present today have already done the exercise in mapping what is education, what is professional regulation, what is practice in different member states. So I think it's almost available in most European countries. It's bringing this information together. I think a more difficult thing is the mobility maps. So how people are moving from one country to another country based on the specialization. And I think it's not an easy exercise because people are using the general system. So you have to find out how they do that. But I see that people are moving from one country to to another country. So I think this is probably what we should do. It takes a little bit more time to map it out, but I think it's feasible, and so it's a feasible thing that can be done. And then altogether, what we should do is to write a common training framework in terms of knowledge, skills, and competences that is based on the European qualification framework. And I think you should not have an agreement with all member states. You should have an agreement in at least 1/3 of the member states, means in Europe now 9 countries. And that's the general idea. But my understanding at this moment in time of specialist nurses, and it was also what Michelle was saying also in Australia, it's at this moment in time, specialist nurses is not well understood. So it's very different from state to state, from country to country. What are the requirements? What is the education? Sometimes it's post for a qualification. Sometimes it's a master. Sometimes it's not a master. Sometimes it's a kind of continuing education. It would help to have a common framework over there. What is required in terms of knowledge, skills, and competences, that we have a general framework to talk about that. And I like what Michelle is saying. I think it's important to make that visible, also to protect the public. That's our main job and our main reason for doing that. And then there is another condition. If you have done that, it should be that this adoption or that this common training framework would be adopted in at least 1/3 of the member states by a competent authority. And if this is the case, what we then have is an automatic recognition for the qualifications that are requiring this common training framework. Of course, it's applying for all member states all over Europe, and of course, some member states can exempt out of that regulation. But I think this is the way forward. And it's not only the way forward just to increase movement between member states. And I think it was a hesitation, what I understood from our European Commission people that are saying, I don't think that's the purpose. Because that from a European Commission perspective, this is the final aim. But I think the final aim is patient safety. The final aim is recognition. The final aim is to have this general framework. If we are talking about an oncology nurse, or if we are talking about some specialist, that this specialist is recognized and understood all over Europe in the same way. And I think this is important. And we see it also in a medical specialty, that a specialist in one country is understood by a specialist in another country. And I think at this moment in time, it's not fully the case. And it's really hindering us in the exchange and the communication. So this is, I think, a pathway we can follow, and it will take some time to develop that, but I think all the conditions are fulfilled to start with that. So my impression is that the role of specialist nurses has become is very, very valuable. I think it's becoming more visible and appreciated during the crisis we are in at this moment in time, but I don't see international recognition and a framework at this moment in time. So I think we should push on this and take that lead and to do that. And I think ESNO is in a very good position to lead this kind of change. Thank you very much for your attention.
Thank you so much, Walter. I think this is indeed one of the challenges, and as you put it already, I think there is a role for ESNO to play together with different organizations, as you nicely pointed out. I think what is also good to hear from you is, as you nicely described, right, the what COVID trajectory has learned us, the impact of the nurse on the lives of people. And I think you were referring, right, if I'm correct, to a discussion we had last year at ESNO's conference, where someone of the European Union was indeed questioning, as in how would that, if that framework would be an end goal or a means to an end. And if I'm correct, it's a latter, right? It's a means to an end.
Absolutely, yeah, I think so, yeah.
Short question, as in, how much time do you think would be needed to get there?
Yeah, I think it depends on how you organize it. I see it is also one question I see in the chat at this moment in time. We have a long list of all specializations, and I think there should be some consensus and certainly some work to be done. What are the specializations we want to have it for? So it might be that they are grouped in some domains. That might be a way of doing that. I don't think you have to do it with 100 because it would take you ages to do that work. Yep. So there should be some consensus in some groups that are useful to take that work. And the experience with other professions, I think the pharmacist did it, and there are some other experience as well. It takes about a little bit more than 1 year to go through that process, because the mapping exercise is quite a difficult thing, but certainly also developing the framework, it's not an easy thing because you have to come to consensus and bring arguments on the table and so on. So there certainly needs some leadership, but it takes some time as well. So if you want to do that to 2030, it's requiring an organized way, but make it not too complicated and not too diverse. That would be my recommendation.
Right, definitely feasible. Thanks, Walter. And you're staying with us, so I
stay with you for the afternoon.
Great. So yeah, so there's more time for questions later on. I have to apologize because I'm eating from your break. I've noticed. So without further ado, let's have a brief break. Have your water, tea, coffee, whatever, and we will reconvene at 2:40. That is in about 12 minutes from now. And then you will be guided into, you will be directed in different Zoom rooms. And the moderators then will briefly explain the objectives of those meetings. And afterwards, we will be back in a plenary and have a discussion, a debate with the keynote speakers and some other invited speakers. So enjoy your break and see you back in a while. Thank you.